Welcome back to the Tea and Toast Club, where we discuss all things geriatrics. This is a mini-series hosted by the Generalists. If you're interested in hosting a Geri podcast, please connect with us. We would love to have you join the conversation about older adults. I'm Dr. Christine Miller, a Care of the Elderly resident at UBC, back at it with Dr. Dunnigan.
In case you didn't get enough of Parkinson's disease on our last episode, today we're going to cover PD management strategies.
Let's go through today's pearls.
Pearl 1. Should I be starting Sinemet as a family doctor?
Absolutely. It's no more risky than any other medication we prescribe. And with the wait times to see a movement disorder clinic or local neurology, your patient could be sitting in the community waiting months to see that person when they could have already done a levodopa trial.
In Parkinson's disease, the primary goal of treatment is to provide good on time. This helps the patient to remain functionally independent for as long as possible, while optimizing quality of life.
There are actually several initial treatment options, although most docs use levodopa first line. 10 or 15 years ago, the pendulum had swung away from levodopa into the camp of dopamine agonists, with the argument made to save levodopa for later in the disease process. Today, we know that levodopa is in fact the most effective PD medication available. Given time, the medication itself does not stop working. Rather, the disease progresses to a point where the patient no longer responds in the same way. The patient has moved from a long duration response to a short duration response.
Once you've decided to prescribe immediate release levodopa, there are different methods to up-titrate with no one exact method. The most important part is to up-titrate slowly so as to lessen the side effect risk. Start at 1 tab TID 100/25 milligrams to ensure the patient gets at least 70 milligrams of carbidopa. Then reevaluate. Some patients will benefit from a further increase. This might mean 1.5 or 2 tabs TID or even higher. There is no absolute limit to the number of levodopa doses per day. Some patients are on 2,000 and 3,000 milligrams per day. If several doses are equally beneficial, the lowest of those equal potent doses can be used. Keep in mind that levodopa is only beneficial for motor symptoms. It does not improve freezing of gait, postural instability, falls, speech difficulties, dysphagia, orthostatic hypotension, cognitive deficits, anxiety, or depression.
Let's talk about dopamine agonists, as that's the other medication which could be started for early symptoms. This includes pramipexole, ropinirole, and rotigotine. The primary argument for starting these agonists is to reduce levodopa-associated dyskinesia and motor fluctuation risks in early PD. However, during the early treatment years, dyskinesia is relatively uncommon. Of note, age does matter. Patients with young onset PD are more likely to experience some dyskinesia in the first 5 years of levodopa treatment, while in older adults, there is only a 16% risk in the first 5 years. The main concern with dopamine agonists is the high side effect risk profile. Patients on these medications are 3 times more likely to develop hallucinations than if taking levodopa. Other side effects include somnolence, leg edema, and impulse control disorders. Although any of these symptoms can occur in a patient who is on any dopaminergic therapy at any stage in their disease, even if they have been on that medication for a long time and it was previously well tolerated, there is a higher risk with dopamine agonists, especially for impulse control disorders. Impulse control disorders refer to pathologic gambling, compulsive shopping, binge eating, or hypersexuality, and it occurs in nearly 50% of patients taking dopamine agonists over a prolonged period of time. PD-related risk factors include dopaminergic therapy, with a dopamine agonist being at greater risk than levodopa, severe non-motor symptoms, significant motor symptoms causing decreased quality of life, and pre-existing frontal dysfunction. Other concurrent ICD risk factors at a general population level include younger age, male gender, psychiatric comorbidity, personal or family history of substance use or bipolar disorder, impulsive personality style, and a family history of ICD. If you suspect ICD, there is a PD-ICD questionnaire which has good validity and reliability in assessing symptom severity in ICD. In the end, conservative use of dopamine agonists seems wise, based on their potential for adverse events.
A third option for treating initial PD is razagiline. It's controversial whether or not this should be started at time of diagnosis in asymptomatic PD patients. The Adagio study in 2009 showed a slower rate of progression on 1 mg razagiline compared to placebo patients who switched to razagiline halfway through the study. However, the 2 mg dose didn't show this effect. At this time, there is no clear evidence for razagiline slowing disease progression or being neuroprotective, and from a pharmaceutical approval level, it is only indicated for symptomatic patients, either as an initial monotherapy or as an adjunct to levodopa.
If you're on the fence and aren't sure if the patient's symptoms are in keeping with idiopathic PD, you can always do a short trial of a dopaminergic medication to assist with accurate diagnosis, keeping a low threshold to abandon the trial if there are any neuropsychiatric symptoms. Measuring a gait speed before and after starting the medication can objectively help you to see if it made a difference.
Pearl 2. What about levodopa side effects? Does it actually matter if they take it on an empty stomach?
The most common side effects are anorexia and nausea. Nausea is due to the premature conversion of levodopa to dopamine in the bloodstream. Circulating dopamine does not cross the blood-brain barrier, except for limited regions, and notably the brainstem chemoreceptor trigger zone. This is the substrate for nausea. There are various strategies for managing levodopa-associated nausea. First, the patient can try taking levodopa with a non-protein product such as dry bread, soda crackers, or a banana. Normally, we advise patients to take levodopa on an empty stomach 1 hour before or 2 hours after eating to ensure that levodopa passage across the blood-brain barrier is not compromised. High-protein diets, greater than 2 grams per kilogram, can decrease the efficacy of levodopa via competition with amino acids in crossing the blood-brain barrier. A high-protein diet causes a closed levodopa gate at the blood-brain barrier so levodopa can't get through. If the patient is having motor fluctuations, they can try a protein redistribution diet where most of the protein is eaten in the final meal of the day. On a side note, dietary fiber and caffeine actually improve levodopa absorption time and motor performance.
Another option for levodopa-induced nausea is supplementary carbidopa. Although this isn't available in Canada as a separate medication, domperidone can also be used. Even though it blocks peripheral dopamine receptors, it doesn't cross the blood-brain barrier, so it's safe to use for PD-GI symptoms. Take it 30 minutes prior to the levodopa dose. It's associated with a small increased risk of ventricular arrhythmias and sudden cardiac death, so avoid in certain populations such as those with prolonged QTC, congestive heart failure, or severe liver disease.
If the nausea is severe and you need an antiemetic, the only safe one is ondansetron. It isn't highly efficacious, but there's no concern about blocking dopamine receptors since it's a 5-HT3 receptor antagonist. Whatever you do, skip the centrally acting dopamine blocking drugs such as Haldol or Maxaran, as they will worsen Parkinsonism symptoms.
Other side effects of levodopa metabolism are orthostatic hypotension and elevated concentrations of homocysteine. Regarding hyperhomocystinemia, age alone is a risk factor. 7% of healthy seniors will have hyperhomocystinemia, along with renal disease. Additionally, levodopa itself has been associated with homocysteine elevation. Increased COMT activity from levodopa can deplete one or more of vitamin B12, B6, and folate, which are cofactors in homocysteine metabolism. Adding a COMT inhibitor doesn't work, as these have been shown to be ineffective at reducing hyperhomocystinemia from levodopa therapy. In the general population, elevated homocysteine levels have been associated with increased neurofibrillary tangles, temporal lobe atrophy, smaller hippocampal size, periventricular white matter hyperintensities, cognitive impairment, significantly increased stroke risk, increased ischemic heart disease and MI risk and a possible increased risk of peripheral neuropathy in levodopa-treated PD. Theoretically, you could measure homocysteine and B12 levels at onset of levodopa treatment and treat homocysteine if it was greater than 11 millimoles per liter. In practice, most movement disorder docs don't do any B12, B6, folate supplementation unless the patient is complaining of peripheral neuropathy, and then they give B12. The only mention of vitamin supplementation in the Parkinson Canada guidelines is for daily vitamin D.
Pearl 3. Let's talk about motor fluctuations next. This refers to the patient's state of being on or off. On is the period, marked by a positive response to levodopa, while off refers to the reemergence of motor symptoms before the next scheduled levodopa dose. Types of on include on with levodopa-induced dyskinesias, on with residual motor symptoms such as tremor, rigidity, or postural instability, and on with both levodopa-induced dyskinesias and residual motor symptoms. In patients with slight to moderate levodopa-induced dyskinesias, residual motor symptoms can actually be more problematic than dyskinesia for ADL performance. Types of off include early morning off. These are symptoms experienced upon awakening prior to the first dose of medication. End of dose wearing off, which is the re-emergence of motor and or non-motor symptoms as the effect of levodopa diminishes near the end of dose interval. Delayed on, when the oral dose takes longer to relieve symptoms than usual. Dose failure, or no on, which is the failure of the levodopa to achieve any motor control. And sudden off, a random and unpredictable switch from on to off. In addition to motor symptoms, non-motor symptoms such as fatigue, anxiety, cognitive difficulties, often described as a brain fog, attention problems, depression, or apathy may occur as part of off periods. If you're looking to assess motor fluctuations, dyskinesia, or dystonia, the MDS-UPDRS Part 4 covers each of these symptoms and their functional impacts.
Less common off complications include akathisia and acute akinesia. Akathisia, or motor restlessness, usually occurs at nighttime, several hours after the last dose of levodopa. This can be managed by providing CR levodopa or a dopamine agonist at bedtime. On the other hand, acute akinesia, known as Parkinsonism hyperprexia syndrome, refers to a sudden and severe exacerbation of PD motor symptoms. The patient can end up in an akinetic state that lasts for several days and does not respond to treatment with anti-Parkinsonism medications. If this happens, look for acute medical illness or infection, which may have triggered sudden worsening of Parkinsonism or use of a dopamine receptor blocking agent such as metoclopramide or an antipsychotic drug. This syndrome was mentioned in the last PD podcast episode in relation to abruptly stopping PD dopaminergic medications.
When treating motor fluctuations, start with the easiest strategies first. Look at the patient's diet and see if they're taking their levodopa with protein, as this will decrease absorption. The most common approach is increasing either individual levodopa doses or dose frequency, although there will come a point, typically when the patient is already taking levodopa 4 or 5 times per day, where increasing frequency any further is impractical. For nocturnal wearing off, take an extra levodopa dose during the night. This could be around midnight or 4 a.m. or first thing in the morning around 6 a.m. Alternatively, you could give a CR levodopa dose 50-100 at bedtime. If this isn't enough to control off symptoms, consider the addition of adjunct medications. COMT inhibitors are usually my first go-tos, then MAOB inhibitors, although they don't work for many people. Only about 1 in 8. They have multiple side effects, and the medication may not be covered. Combination therapy with levodopa and a dopamine agonist may help counteract motor fluctuations. The addition of a dopamine agonist reduces off time by around 15%, while allowing a lower dose of levodopa to be used, but there's that big side effect risk that we discussed earlier.
Moving on to dyskinesias. Keep in mind there are two types of drug-induced dyskinesias. One, levodopa-induced dyskinesia, and two, tardive dyskinesia, which occurs due to long-term use of dopamine D2 receptor antagonists, such as antipsychotics. When thinking about PD-related dyskinesia, just as too little brain dopamine translates into motor slowness, too much dopamine results in excessive movements called dyskinesias. Dyskinesias are often attributed to levodopa therapy, but any medication that enhances the effect of dopamine, such as dopamine agonists, MAOB inhibitors, or COMT inhibitors, can trigger dyskinesia. Although uncommon, severe dyskinesias may result in rhabdomyolysis and dehydration.
There are three main types of dyskinesias. Peak dose dyskinesia is the most common, and as it sounds, it occurs at the time of peak plasma levels of levodopa. It is characterized by hyperkinetic, uncontrolled involuntary movements of the head, trunk, or limbs. Dystonia is an involuntary, sustained muscle contraction, affecting one or more areas of the body. Nocturnal wearing off dystonia, usually painful foot flexion and inversion or hyperextension of the great toe, occurs early in the morning before a dose of levodopa. Treating nocturnal dystonia is similar to treating nocturnal offs. The patient can take an extra levodopa dose during the night or first thing in the morning, or you can prescribe CR levodopa at bedtime. You can also have wearing off dystonia during the day or peak dose dystonia, but these are not typically painful. The third type of dyskinesia is diphasic dyskinesia. This type of dyskinesia is the least common, with two separate periods of involuntary movement after a levodopa dose. The first period occurs with turning on, and the second with wearing off. It is characterized by large, uncontrolled movements of one or both legs and is more common in young onset PD. Other than the MDS-UDPRS Part 4 scale, there are several dyskinesia-specific scales. The Unified Dyskinesia Rating Scale and the Rush Dyskinesia Rating Scale.
In regards to treatment, it's unnecessary to treat mild, non-distressing dyskinesia. Once symptoms begin to bother the patient, your first step is to shorten levodopa dosing intervals or lower the doses of either levodopa or adjunctive therapies. The goal is to lower dopaminergic stimulation below the threshold of inducing dyskinesia with the realization that it may result in reemergence of Parkinsonism symptoms. The dyskinesia threshold is highly variable for patients and can occur at relatively low therapeutic doses of levodopa in some patients. The patient needs to answer the question of which is worse, the levodopa-induced dyskinesias or their motor symptoms, which causes the most problems for the patient in their daily activities. Then, the focused treatment strategies on whichever is the biggest problem for the patient. If lowering levodopa doses didn't help the dyskinesia, next try adding on a COMT or MAOB inhibitor. Remember to lower the levodopa dose when prescribing adjuncts. If there is still poor dyskinetic control, add amantadine, 100 milligrams BID or TID. It's fairly well tolerated, but watch for anticholinergic side effects, especially confusion or hallucinations, along with livedo reticularis, lower extremity edema, and elevated LFTs. When all of the previous treatment strategies fail, neurosurgical approaches should be considered in appropriate patients. Pearl 4. What about non-motor symptoms? How should those be treated?
Let's go through sleep management first. For REM sleep behavior disorder, RBD, the goal of treatment is to reduce behaviors and lower risk of injury, both for the patient and their bed partner. Melatonin is first-line therapy for RBD. It is well tolerated in the elderly, even if there is comorbid dementia or delirium. Dose range is variable from 3 to 12 milligrams, and usually a higher dose is needed to augment behaviors. Most patients experience partial improvement in the frequency and severity of RBD symptoms and a reduced likelihood of injury. If behaviors are inadequately suppressed with melatonin, then it's reasonable to add on a low-dose clonazepam. Generally, you want to stay below 1 milligram per night of clonazepam. Start off around 0.25 milligrams and go up to 0.5 milligrams. Some patients start to have side effects once you get above 0.5 milligrams, and if you get to the 1 milligram mark, Most patients will have side effects. The other thing to consider is if the patient is on any SSRIs or SNRIs, as these can exacerbate acting out dreams and you may need to wean them down.
Insomnia can be levodopa responsive in PD, so try adding on levodopa CR at bedtime, or alternatively consider a dopamine agonist such as the rotigotine patch. If the patient isn't already taking melatonin, then this is a good addition as well. Low doses of sedating antidepressants such as trazodone could also be used. Newer sleep medications have also been approved in Canada, such as limborexant, which is an orexin receptor antagonist. If the patient reports difficulty turning over in bed as one of their insomnia causes, I highly recommend use of satin sheets and silk PJs to improve bed mobility. This will make a world of difference to your patient.
For advanced phase circadian rhythm disturbance, think about using either a light box or again melatonin. If hypersomnolence is the issue, use some of your non-pharm strategies like caffeine or taking a strategic power nap. This means napping for no longer than 20 or 30 minutes in the late morning or early afternoon. Look through their med list, as use of dopamine agonists can cause excessive daytime sleepiness, so you may want to try a lower dose. If you're thinking about medications, then venlafaxine is the activating agent. Modafinil has mixed results. Keep in mind that it can actually worsen agitation or cause psychosis. Similarly, methylphenidate only has some small studies with conflicting results and has the same risk of worsening agitation. Patients with bothersome restless leg syndrome should be screened for iron deficiency. Potential treatments for RLS include optimization of dopaminergic therapy or GABAergic agents like pregabalin.
Autonomic dysfunction covers a broad range of symptoms, so we're going to start at the top. If there's swallowing dysfunction, get SLP involved early on. They'll be able to teach the patient things like mindfulness, not talking and eating at the same time, change in diet consistency, taking pills with applesauce, chin tuck, and good oral hygiene. If doing any investigations, you could consider a barium swallow study. Unfortunately, dysphagia has a limited levodopa response, unlike the improvement seen in motor fluctuations. For drooling, you may want to start off with gum chewing or sucking on hard candy, which converts swallowing into a more conscious action. If you want to actually decrease saliva production, you'll need medication on board. Sublingual administration of 1% atropine eye drops, 1 drop once or twice daily, may reduce saliva production while avoiding systemic anticholinergic effects, although this is off-label use. We use a lot of glycopyrrolate in palliative care, and it works for PD patients as well. Although it's an anticholinergic, it does not cross the blood-brain barrier, and so cognitive function is not impaired. But it still can produce peripherally mediated adverse effects such as urinary retention and constipation. Intraparotid Botox injection, either type A or B, has now become the primary treatment option for treating troublesome drooling in patients with PD, typically producing benefits that last for 3 months or more.
For nausea, recommendations include smaller, more frequent meals and ondansetron or domperidone. Make sure to avoid D2 receptor blockers such as Maxaran, as this will worsen Parkinsonism. A gastric emptying study could be considered if needed. Constipation is the next symptom. Treatment of constipation in PD largely parallels the treatment of idiopathic constipation. Start by removing any offending drugs if possible. Think about opioids or anticholinergics. Chat with the patient about increasing fluid and fiber. Remember, if you increase fluid without increasing fiber, all you're doing is giving the kidneys a workout. Exercise, positioning, toilet stools can really help, and abdominal massage. Provide daily PEG rather than PRN, and think about supplements such as probiotics or magnesium. If you're aiming to improve bowel regularity, magnesium citrate is the formulation you want. Remember to avoid calcium and iron, as these can be constipating. Lubiprostone, a chloride channel activator, can also be helpful in PD-associated constipation.
Although orthostatic hypotension is very common in PD, the key to treatment is whether or not the patient is experiencing symptoms from their orthostatic hypotension. Start by avoiding or decreasing doses of aggravating medications. This includes meds such as antihypertensives, diuretics, alpha blockers, anticholinergics, and more. Avoid aggravating factors such as large meals, alcohol, and exposure to warm environments such as hot tubs, hot showers, or prolonged standing in hot weather. Talk to the patient about slow position changes. They can use calf pump exercises before standing. They can also increase their fluids, aiming for 2 to 2.5 liters per day, and increase their dietary salt up to 2 grams per day if no concomitant cardiac issues. They can also use cinder blocks under their head of their bed, allowing them to sleep in a reverse Trendelenburg position, which can help with morning orthostasis. Additionally, they can use thigh-high compression stockings, not knee-high, as these are generally ineffective. They might also consider abdominal binders and compression shorts. They are typically well tolerated and effective. For medications, midodrine is first line, followed by fludrocortisone. Both of these can cause supine hypertension, so make sure to give the last dose of the day in the afternoon, rather than in the evening. PD patients can experience both orthostatic hypotension and supine hypertension. A very high supine systolic blood pressure, such as greater than 160, warrants treatment consideration. This might mean giving a short-acting drug at bedtime, such as an ACE inhibitor or an ARB, a central alpha-2 agonist like clonidine, or a vasodilator, either transdermal nitroglycerin or hydralazine.
Regarding urinary incontinence, start by reducing intake of fluid in the evenings. This includes caffeine and alcohol. Additionally, you could recommend sleeping with a head-up tilted bed to reduce urine production. For OAB symptoms, mirabegron is your number one drug. It demonstrates similar efficacy to the anticholinergic drugs without the risk of anticholinergic effects, although it can cause orthostatic hypotension. Avoid other OAB anticholinergic agents as they will significantly worsen cognitive function. Botulinum toxin injections into the detrusor muscle works well especially for women. For erectile dysfunction, you could try sildenafil 1 hour before sex, although again there is a risk of orthostatic hypotension. Other drugs in this class can also be tried.
When thinking about pain, it's more common in PD than we realize, with around 50% of all PD patients experiencing some sort of MSK pain. If the pain seems to fluctuate with on and off periods, it may be levodopa responsive, and so adjustments to this medication could be tried. Duloxetine and a low-dose gabapentin could be used, although they may worsen hypersomnolence. If there's no kidney or other contraindications, NSAIDs could be trialed as well. For dystonic postures, Botox injections have shown good effect. Finally, if there's a localized area of pain, the patient may benefit from trigger point injections.
Prol 5. Parkinson's disease dementia, or PDD, similarly to dementia with Lewy bodies, DLB, was a type of subcortical dementia, primarily with frontal executive dysfunction. Slowness of thinking, decreased motivation, distractibility, with memory loss occurring in later stages rather than the amnestic picture you see in cortical dementias like Alzheimer's disease. Risk factors for PDD include older age, disease duration, early visual hallucinations, RBD, axial rigidity or gait impairment, and early visual spatial problems. If you have PD first and then develop PDD, chances of having a concurrent Alzheimer's disease are smaller, around less than 20%. This is slightly different than in DLB, where most patients will have changes from both Lewy bodies and Alzheimer's disease. Additionally, there is a significant cholinergic effect in PDD and DLB, much more severe than in Alzheimer's disease. Practically, this means that the acetylcholinesterase inhibitors tend to work better in PDD and DLB than in Alzheimer's. Risk of progression from PD to PD-MCI is around 25%. 20% of PD patients with MCI are likely to convert to dementia, while 28% or so will revert back to normal cognition. Keep it simple with the 1/3 rule here. The estimated cumulative risk of dementia in PD is around 80%. For treatment, technically rivastigmine is the only acetylcholinesterase inhibitor that's approved for PDD. Donepezil works well if the patient doesn't tolerate rivastigmine. Efficacy for galantamine and memantine is inconclusive in PDD. Keep in mind that exacerbations of Parkinsonism and tremor have been observed during treatment with cholinesterase inhibitors.
PD-associated psychosis is common. Visual hallucinations are the same in both DLB and PDD. They tend to start as transient illusions, shadows moving in the peripheral vision, often at night, and then over time, visual hallucinations become fully formed. The patient may see detailed animals or small people. Often these are benign, but they can also be very threatening and distressing to the patient. Non-visual hallucinations, such as auditory, tactile, and olfactory, can also be reported. Paranoia and delusional thinking is only seen in a small number of patients. There are multiple mechanisms for the development of hallucinations. The retina has dopamine, so it may be related to a lack of dopamine here. There can also be decreased perfusion to occipital lobe, and Lewy bodies can reside in the ventral visual stream. This is the area from the occipital lobe to the temporal lobe.
The treatment approach for PDD psychosis is threefold. First, you want to rule out delirium. Next, look at the patient's medications and reduce any which may be causing psychotic symptoms. Start with the least potent medications first, so go from anticholinergics to mantidine to dopamine agonists to levodopa. Third, consider adding on medications to help reduce hallucinations. Choices for this include acetylcholinesterase inhibitors, which is first line, and then either quetiapine or clozapine as second line. Clozapine has best evidence across multiple trials, but it's not practical due to the monthly lab monitoring requirements. Sometimes you may see a practice difference. Most neurologists don't tend to use clozapine, but a lot of psychiatry and movement disorder docs do. Quetiapine is commonly used in practice, but studies show mixed data for efficacy. It's well tolerated, especially in lower doses. Start with scheduled quetiapine, 6.25 or 12.5 milligrams at bedtime, then slowly up titrate. If behaviors are worse in the evening, try adding on an afternoon dose. PRN quetiapine can be ordered for agitation or distressing hallucinations that are unresponsive to non-pharm methods. Side effects of quetiapine include hypotension and sedation. It's not recommended if there's a history of prolonged QT interval, as it may increase likelihood of developing torsades de pointes. AST and ALT elevations may occur in up to 30% of patients on long-term therapy with quetiapine, but elevations are uncommon above 3 times the upper limit of normal. If the patient feels their motor symptoms are mildly worse on quetiapine, you could switch to clozaril, although there is no clear evidence that low-dose quetiapine worsens Parkinsonism. In the US, pimavanserin is approved for hallucinations and delusions in PDD, but not yet in Canada. If the patient is admitted as an inpatient and there's a safety risk from their behaviors, you could use the olanzapine in very, very low doses if you needed a rapid response and the quetiapine wasn't providing a long enough effect. Remember to avoid all other atypical and typical antipsychotics, as the affinity for D2 receptors is too high and it will worsen motor problems.
Finally, anxiety and depression are common in PD. Depression can be seen in early disease, while in advanced stages, 60% of patients experience depressive symptoms. As mentioned earlier, mood symptoms can result during off times and may be levodopa responsive in this case only. SSRIs are first line for both. The SAD-PD trial in 2012 showed both paroxetine and venlafaxine extended release are effective in treating depression in PD patients. However, clinically you're going to want to avoid paroxetine due to its anticholinergic properties. A single antidepressant, such as escitalopram, is still safe for patients who are concurrently on an MAO-B inhibitor. There is not a significant risk for serotonin syndrome. If anxiety co-occurs with restlessness, poor sleep, or loss of appetite, mirtazapine may be a good option. Start with very low doses and administer at bedtime.
And that's a wrap for today's episode. If this episode was helpful, pass it on to your colleagues. Thanks to our peer reviewer, Dr. Tuck. Opinions expressed are our own and don't represent any affiliated organizations or institutions.